Hi, everyone. Thank you so much for joining us today for our webinar. This is the first in the Women's Caucus series focusing on critical issues in women's health webinar series for 2021. And we are very happy to partner with Latinx on Voices. I'm sorry, I probably messed that up. Paulina. But thank you so much for joining us today. We're going to go ahead and get started. Thank you all for being on time. Today, our topic is going to be focused on violence against women. I'm Michelle Williams, and I'll be serving as your host for this session. We also have our collaborator, Paulina Sosa, who's going to be serving as a moderator for the question and answer session. So before we get started, I just wanted to provide a little bit of background information. For those of you who are not familiar with the organizations that are hosting this activity, it's the Women's Caucus is an affiliate group of the American Public Health Association. And the goal of the Women's Caucus is to really focus on providing a forum and a platform to discuss women's health issues that really aren't discussed enough. And then Latinx Voices on Salud is focused on empowering and inspiring Latinx communities to speak up and share their stories, and also to advocate for policies aimed at improving the health status of Latinx. So before we get started with our introductions, I did want to let you know that we are offering a free CEU for attendees. I'll put this link in the chat box several times during the activity. And then we'll also have an evaluation that's available for you to provide feedback on the webinar, and also suggest some other topics that you would like to hear about from experts focused on women's health issues. So our first speaker will be Dr. Jamila Stockman, and she is an associate professor and vice chair of global health at the University of California, San Diego School of Medicine. And her work that she's going to speak about today is going to be focused on the intersection of COVID-19 stressors and intimate partner violence among U.S. adult women, and the results from a study that she's conducting called the COPE study. Our second speaker for today will be Dr. Priscilla Simms-Roberson, and she is an assistant professor at University of Tennessee in Chattanooga. And this presentation that she's going to give today is going to be focused on violence against women, how community health workers can make a positive impact. And our final speaker today will be Sarach Shannon. She is the executive director of Hesperian Health Guides, and she'll be talking about practical information to prevent sexual harassment and violence against women. Each speaker will have 15 minutes for their presentation, and we'll save all questions and answers for the end. However, if you do have a question that emerges during a person's talk, feel free to put that in the chat box, and our moderator, Paulina, will make sure to address that during our question and answer session. So I'm so proud that everyone is here, and I'm just excited. So we'll go ahead and get started with our first presenter.
Okay, good morning, good afternoon, everyone. Today, I will be presenting on the intersection of COVID-19 stressors and intimate partner violence among U.S. adult women. And I'd like to thank Dr. Williams and the Women's Caucus of the APHA for the warm invitation to participate in today's webinar. So first, I'd like to start off with acknowledging the rest of the research team. And those individuals are Brittany A. Wood and Catherine M. Anderson. Catherine M. Anderson is a multi-investigator of this project in which I will be presenting on today. I'd also like to thank the study participants who generously provided the data for this research, and acknowledge the funding that enabled this research to be possible. And that funding came from the University of California, San Diego, Office of Research Affairs, the Office for Equity, Diversity, and Inclusion, and the Office of the Chancellor. We have no conflicts of interest to disclose. And so I'd first like to launch into a little bit of background information about intimate partner violence during the COVID-19 pandemic. So beginning in March of 2020, after the first initial cases of COVID emerged in the US, and then subsequently a few months thereafter, we started to see news reports and news articles focused on the rise in domestic violence calls amidst the coronavirus lockdown and quarantines that were mandated across the states. And then shortly thereafter, there were a few commentaries that were released and published, and these commentaries focused on the impact of COVID-19 on domestic violence in the United States, as well as elsewhere in the world. And then now what we're starting to see is research emerge that was conducted during the early stages of the COVID-19 pandemic. And so this first article here listed on the bottom was published a couple of months ago, and it focused on changes in intimate partner violence during the early stages of COVID in the US. And it showed that among about 300 or so US adults, that intimate partner violence got worse during the early stages of COVID-19 for about 17% of those 300 individuals. So intimate partner violence has become known as the shadow pandemic. And there's a lot of other shadow pandemics, such as depression and PTSD, that has emerged as a result of COVID. And so we know that in the US, in the past 12 months, pre-COVID, about 5.5% of women reported experiencing IPV. And these estimates come from the CDC, and they're based on 2015 annual estimates. So the United Nations, they met and convened and identified a few exacerbating factors that can worsen situations of domestic violence. And these factors include security, health and money worries, so not having enough funds to in your household, so to buy food or just even purchase regular household expenses, living in cramped conditions, being isolated with the abusers, and this is due to the quarantine measures that were in place, movement restrictions, and deserted public spaces. So sorry, something happened with my slides here. So what we sought to do was to determine the proportion of US adult women who have experienced overall IPV and subtypes of IPV victimization early in the COVID-19 pandemic. We also sought to examine the associations between COVID-19 stressors and overall IPV and subtypes of IPV victimization among US adult women. So how did we do this? We conducted a cross-sectional web-based study between May and June of 2020, and the study is entitled the COPE study. Women were eligible if they were at least 18 years of age or older and also resided in the US or one of its territories. We recruited women from social media, primarily through Facebook advertisements, and we had a wide range of advertisements that were deployed that captured a range in age and variations in ethnic backgrounds to be able to recruit an ethnically diverse population of women. Women who were interested in participating clicked on a link that directed them to the webpage for this particular study. They then provided informed consent and then completed a screener. Those who were eligible after completing the screener completed a 20-minute online self-administered survey. And it's important to note that we had safety provisions for women in place at every point of their participation in the study, from the informed consent to the screener to the actual completion of the survey. So there were resources available. There was, women didn't have to complete the interview in one sitting, and they could come back using a password or a code that was emailed directly to them. Participants received $20 in the form of an Amazon gift card, and all study procedures were approved by the UCSD Human Research Protections Program. So 682 women clicked on the link, And then of those, 634, or 93%, completed the screener. Among those women, 627, or 98.7, were eligible. And of the eligible women, 491, or 71.1%, consented and completed the survey. So for this particular analysis, we focused on women who responded to all of the IPV and COVID-19 stressor questions, yielding a sample size of 326 women. The survey included multiple measures, including demographic characteristics, IPV victimization overall, and subscales of IPV. The subscales we focused on were psychological, physical, and sexual IPV. And we used the revised conflict tactics scale to measure IPV. And then we modified the response options in the revised conflict tactics scale to be inclusive of whether an individual experienced at least one incident of these different types of IPV from March to May 2020, which meant that they experienced it early COVID, or whether they experienced it pre-COVID, which meant they didn't experience IPV during March to May of 2020, but they experienced it before March of 2020, or no history of IPV whatsoever. The COVID-19 stressors that we were interested in were identified by the UN as well as World Health Organization. And these stressors included not having enough food and no money to buy more, not having enough money for rent, homeschooling children, and loss of income. So what did we find? Well, among our sample of 326 women, the average age was 33 years old. The sample was ethnically diverse, although it's important to note that half of our sample self-identified as being white. We had a highly educated sample. Only 1/5 had a high school education or less. 1/5 were unemployed. Approximately 40% were living with a significant other at the time of the survey, and the majority of women resided in an urban or suburban residential community. When we look at the distribution of COVID-19 stressors in the sample, you can see here that a large proportion of women endorsed each of these stressors. So about 80% of women reported not having enough food and no money to buy more, as well as not having enough money to pay rent. 75% reported homeschooling children, and 60% reported a loss of income. Now, when we look at IPV victimization and COVID-19 stressors, it's quite interesting what emerged. So on the left-hand side, you can see that 54% of women reported experiencing IPV early COVID, so during that early stage. 11% reported experiencing IPV pre-COVID, and 35% reported no history of IPV. And on the right-hand side, we have a bar chart. The blue bars indicate whether a woman experienced IPV during COVID, and then the purple bar indicates a woman with no COVID-specific IPV experience during that time. So what's important to the take-home message from this particular chart is that a higher proportion of women who experienced IPV during COVID reported reported not having enough food and no money to buy more, as well as not having enough money to pay rent, compared to those who did not report a history of IPV during COVID. And there were statistically significant differences observed between the IPV groups for the second stressor noted here, so not having enough money to pay rent. When we look at the different subtypes here, we have for psychological IPV, again, on the left-hand side, you can see that 49% of women experienced psychological IPV during COVID, 12% pre-COVID, and 39% no history of psychological IPV. And on the right-hand side, again, a similar pattern emerged where we have women who experienced psychological IPV during COVID reporting a higher proportion of experiencing the two stressors there. So the first two stressors, so not having enough food and not having enough money, in comparison to those women who did not experience psychological IPV during COVID. For physical IPV during COVID, 21% of women experienced this, 10% experienced this pre-COVID, and 69% did not experience physical IPV at all. And what we can see here on the right-hand side Again, a very, very similar pattern here with the two stressors that were most often reported by women who experienced physical IPV during COVID, being not enough food and no money to buy more and not enough money to pay rent. We did have an unexpected finding emerge for the third stressor there, homeschooling children. And what happened there is, what this means is that a lower proportion of women who reported physical IPV during COVID reported homeschooling children compared to women without experiences of IPV during COVID. Sexual IPV, 33% of women experienced this during COVID, 15% experienced this pre-COVID, and 52% did not have any experiences of sexual IPV. And again, on the right-hand side, very, very similar findings emerged. So what can we conclude from this analysis? Well, in this sample, approximately 1 out of 2 women experienced IPV victimization during the early COVID-19 pandemic in the US. And the proportion of women reporting the different types of IPV, so psychological, sexual, and physical IPV, were higher than the national past year estimates. So that's really important. So during that early period, that 3-month period, we found that the proportion of women who endorsed these different types of IPV were higher than past year estimates based on CDC. The final conclusion is that across all types of IPV victimization experiences, so physical, psychological, and sexual, there was one stressor that seemed to consistently emerge as significant, and that particular stressor was not having enough money to pay rent. So what can we do about this, and what does the public health implications of this work mean? So what we know based on this stressor that consistently emerged throughout the different types of IPV, we know that reaching women experiencing economic disruptions during a pandemic is vital in order to address IPV in this particular context. We also know, given the high proportion of women who experience IPV overall and the different subtypes of IPV, that the consequences are often adverse mental health and substance use. And so what we really need to think about is expanding, making sure that the priorities moving forward are focused on funding and service provision to really account for the high rates of IPV during COVID and also address these adverse mental health and substance use conditions that may also emerge. And then finally, our research is the first that will be soon to be published that presents scientific evidence that links IPV to COVID-19 related stressors. And so what future research should really do is to build upon what we have found and further elucidate and clarify what this really means. And how that can be done is through the development and implementation of longitudinal studies, as well as integration of qualitative research findings. And it's only with this comprehensive picture that we'll be able to facilitate targeted intervention efforts among US women in the United States. So with that, I would like to thank you, and my contact information is here for those who would like to continue the conversation if the Q&A session doesn't allow for me to respond to all of the questions. So thank you.
Okay, my name is Priscilla Simms-Roberson, and I'm in Chattanooga, Tennessee. And again, I am a nurse practitioner, and I am also certified as a sexual assault nurse examiner and work at a local rape crisis center here. So today I'm going to talk about violence against women and how community health workers can make a positive impact. So my learning objectives is we're going to talk about the different types of violence against women. We're going to talk about some risk factors of domestic violence, sexual assault, and human trafficking. And then we're going to talk about some resources. I always do a trigger warning before my presentations. Obviously, you guys knew what this topic was about, but if you feel like you need to leave, I totally understand. And we all here probably know this very well because you're participating today, but violence is definitely a healthcare issue, and people are kind of starting to take this more seriously. Obviously, I'm a healthcare provider, so in the healthcare field, it's obviously becoming kind of a bigger topic as well. But as we all probably know, that violence has significant effects on people's health. It has direct effects that can actually cause death, like in domestic violence. But there's also a lot of indirect effects, which are kind of new things that are coming out related to violence and chronic disease, quality of life, mental health problems, and increased risk of perpetration. First, here's some domestic violence statistics. In Tennessee, 40% of women and 32.5% of men will experience domestic violence during their lifetime. Domestic violence is the primary cause of traumatic injury to women. Again, I said this earlier, but victims of domestic violence have increased chronic health problems. And then after a domestic violence event, 49% of victims want healthcare assistance. However, only 18% of victims seek medical treatment. So one of the things I'm going to talk about today is kind of how to help patients get that medical treatment that they may want. These statistics are about sexual assault, which is obviously another type of violence against women. 1 in 3 women are survivors of sexual violence, and 1 in 6 men are survivors of sexual violence. Most people know the person who assaulted them, and also most sexual assaults are not reported to police. The majority of sexual assaults happen at younger than 25 years old, and a lot happen younger than 18 years old. Human trafficking is kind of a newer topic that's come out just within the last few years, and people are really starting to recognize it as a major healthcare issue as well as a violence issue. 1 in 4 children who run away will be propositioned by a sex trafficker within 48 hours of leaving home. In the United States, a child is sold for sex every 2 minutes. I always like to point this out because a lot of people think of human trafficking kind of as an international issue, or something about where human trafficking is crossing borders. But that's really not what human trafficking is. And there's a lot of human trafficking that occurs here in the United States. The average age of a child sold for sex is 13. And 41% of children are trafficked by a family member. Again, I'd just like to point this out. Human trafficking is not an international issue. It's not really even a big city issue. I'm in Chattanooga, Tennessee, and this is just an article from a couple years ago where we've had multiple human trafficking arrests here in Chattanooga, and we're not really that big of a city. So don't just kind of discount human trafficking as an issue because of where you live. So here we go. So the topic for today is what we can do about it as community health workers, or as patients who are working, as providers who are working with any clients in the community. So number 1 is know the signs. Right? Think about physical injuries that you see that may not really add up to the patient's story, or physical injuries that the patient doesn't want to talk about. A lot of victims of violence have trust issues. So they may have difficulty trusting you or trusting other people. So that could be a red flag that you might need to know the signs of. Isolation. A lot of clients who experience violence either isolate themselves and aren't able to see friends, aren't able to see family. So they're very isolated from the community. But at the same time, a lot of people who experience violence are forced into isolation. So a perpetrator of domestic violence may not let the victim leave their house. Or human trafficking victims, they may be isolated from a lot of other people. So if you pick up or detect any type of isolation going on, that could also be a sign of some type of violence that's going on. I also like to always point out that there's no such thing as a normal or a typical response to any of these types of violence. Right? So don't be looking for that kind of stereotypical response to sexual assault or to domestic violence or human trafficking, because everybody responds completely differently, and that's okay. We, as people who work with clients, just need to be able to pick up on the signs. And then the biggest part of what we need to do, here's a good slide that I like to show people about general indicators of human trafficking. So I know there's a lot of words to see on this, and I'm not going to read them all. But this is just a great kind of checklist of different behaviors or indicators for human trafficking victims. Obviously, I work at a rape crisis center, so I most often see sex trafficking, which is down in the bottom right-hand corner. But there's multiple types of human trafficking that can occur. So these are great indicators to know about. So now, the biggest thing that we can do as community health workers working with different clients is screenings. If you pick up on a red flag, don't be afraid to ask questions. Okay? I'm sure we all know, we can probably relate back to some sort of personal experience we've had before, where we are with a healthcare provider or with somebody, even a friend or family member, and it's really hard to talk about difficult subjects. So it's really hard to bring up and initiate discussion about something that's hard to talk about. However, if you're asked directly about that difficult subject, or if you're given the opportunity to fill out some type of screening, then it's oftentimes easier to say yes to screening questions than it is to bring something up out of the blue. So I really like to point out how important screenings are, and just asking questions and giving your clients the opportunity to say yes, they are experiencing something. Because a lot of times it's a lot easier to disclose when all you have to say is, yes, that's happening to me, rather than initiate the discussion yourself. So screenings are very important. There's lots of different screenings out there for sexual assault, human trafficking, and domestic violence. There's different ones for kind of different places that you work. Healthcare provider screenings might be slightly different than, for example, a health department kind of public health educator screening, but they're all really important to do. And one thing that I like to point out is the second bullet point there. The question of, do you feel safe at home, is kind of an unreliable and outdated question. So it's really not recommended to use that anymore. If you ask an 80-year-old female if they feel safe at home, then they might be thinking safety is like, do you have rugs on the floor? Okay. For example, rugs can be very dangerous to older adults because they cause lots of falls. So that type of feeling safe at home is very different than the purpose of the question. So the 2 bullet points below that is kind of a better way now that we know to ask questions to find out if people are experiencing some sort of violence at home. So the question, has anyone hit, kicked, slapped, punched, or otherwise physically harmed you in the last year, is a great screening question to ask. And then, have you been coerced or forced to have sex when you didn't want to in the last year? So that's a great screening for sex trafficking or for sexual assault. So instead of just saying, do you feel safe at home, we really recommend that you do very specific questioning now, again, to get more accurate answers. Here's another example of a screening. You guys may have seen this kind of on social media. I've seen it on Facebook a couple times. This is a picture from a medical office where when you go to the bathroom, you leave a urine sample. I'm sure you have all done this before when you've gone to a healthcare provider office before. This is in the bathroom, and it specifically says, please write your initials with the red marker on the specimen cup if you're experiencing intimate partner violence, domestic violence, or anything else you wish to discuss in confidence with your provider. So this is super easy and super safe to do. Patients do it when they're in the bathroom alone. And if the provider sees that red pin, then they should know that there's something that the patient or the client wants to talk about. So obviously you guys probably aren't all working at places where urine samples are left, but you can kind of tweak this idea and come up with something similar on your own, wherever you work. So think of some discrete method that patients could disclose that they need to talk about a sensitive topic with you or with somebody else without having to come out and say it. This is a research study that was done on human trafficking. And what it did was it was done on victims or survivors because they were out of the system. And the question is, did you ever come into contact with any, and then there was basically a fill in the blank here, during your exploitation? Right? So you can see the survey section down at the bottom, the light blue, that's kind of what the fill in the blank was. So this question is, did you ever come into contact with hotels or motels during exploitation? 79% of survey respondents said yes, they did come into contact with hotels and motels. So I use this slide to point out when I'm presenting to healthcare providers that 69% of human trafficking survivors said yes, they did come into contact with a healthcare employee during their exploitation. So I really like to point that out because human trafficking victims, they're not kind of holed away in some house somewhere. They are out in the community. They're contacted or they're contacting financial service industries, transportation. They're on social media. They're going to hotels and motels. They're seeing healthcare providers, and they are in the housing and homelessness systems. 39% said yes to that. So patients are really out there contacting lots and lots of people. So if you think about how many victims you may be coming into contact with, you can see why screenings may be so important to do and really picking up on those red flags or cues that you may see. The first contact person after a sexual assault is a really big deal. A negative reaction is worse and more damaging than no reaction at all. So victims who don't even tell patients that, tell people that they were sexually assaulted actually do better off than a negative reaction. So I like to use this slide just to point out to everybody about how important having a helpful response or reaction is. So we want to stay away from victim blaming. We want to stay away from why type questions, like why did you go to the bar? Why were you wearing that outfit? Those are victim type blaming questions. So we want to have positive, helpful reactions, and I'm going to talk about how to do that next. This is an example about kind of how sexual assault is treated differently than a lot of other traumatic situations. So the example here is, quote, someone says, "My daughter died in a car crash." And down here in the blue, you can see the response is, well, that's what she gets for not taking the bus. So clearly that is a ridiculous response that no one would ever say to anyone because it is not a positive, helpful statement. So this would never happen in a real life situation. However, when patients disclose sexual assault, unfortunately, we do get some of these ridiculous responses. And so just be careful that you're not making any of those statements. So 6 steps to support a survivor. We're getting to the end here. This is kind of what you can do to have a positive reaction when there's any victims of violence who disclose to you. You want to listen. You want to validate what is happening to them. You want to ask what you can do to help. And number 4 is super important. You need to know where to point someone to for more help. So the worst thing that can happen is someone's disclosed to you and you're very supportive and you're very kind to them, but then you don't do anything about it. So one thing that we all need to be prepared for is what to do when someone discloses to us. So when someone tells you they've been sexually assaulted or tells you they're in a domestic violence situation or a human trafficking situation, what are you going to do next? So you need to kind of have your referral resource planned. Keep an open heart and make sure and care for yourself because this can be a difficult field to work in. Here's some examples of communication techniques. Again, I'm not going to read them all to you because I'm getting short on time, but these are some good examples about positive, helpful things to say to validate and communicate belief. And lastly, here I have some interventions. So some things that you can refer clients for is emergency medical care if it's needed, a forensic medical exam by a healthcare provider. So these are fairly common now in the United States, and they're performed for sexual assault, but also for human trafficking, domestic violence, and I know we're not really talking about it here, but child abuse, elder abuse, and lots of things. So forensic medical exams are becoming more common. Obviously, you can refer to law enforcement if needed. Counseling and then advocacy services are all different options that you may have. Crisis hotlines. So number one, I have know your local resources. So obviously we're doing a national presentation today, so I didn't want to list specifics, but wherever you are, you need to figure out what your local resources are. What are the organizations that you need to refer to for sexual assault or refer to for human trafficking or domestic violence? Below that, I have national hotlines listed. So we have a national sexual assault, national domestic violence, and national human trafficking hotline. So these are all other resources that you can utilize or you can give to clients to utilize. So that's the end of my presentation. Hopefully I stayed within my 15 minutes. If you have questions, we can ask them at the end, but hopefully you learned a little bit about kind of what you can do as far as screenings and helping patients disclose and then getting them the care that they may need. So thank you for attending.
Hi, I'm getting my slides up. Hi, I'm Sarach Shannon, and I'm really pleased to be speaking with you today. I'm the Executive Director of Hesperian Health Guides, and I'm going to be speaking today about our experiences developing and distributing practical resources that are used to prevent sexual harassment and violence against women. Some fast background about Hesperian. We are best known for developing frontline and community health materials that are used to train frontline health workers and community health workers and used as community health promotion materials. Where There Is No Doctor is our best known book. And it and our other resources are in over 80 languages through an open copyright policy. We produce print books. These are some samples. Those are also distributed in free online content that's available right now in 36 languages. We do booklets and free mobile apps. And I'll be speaking specifically about two resources that have been widely used to prevent gender-based violence and sexual harassment. The first of which, and just as context, as we're aware, violence suffered at work or in the home leaves physical and emotional scars, and fewer than 40% of victims of violence seek help. And while workplace harassment is often ignored, especially when victims are poor. It was really interesting to listen to Priscilla's presentation about the role of health workers, and formal and frontline health workers in the community and the workplace can play an important role. But they frequently lack experience, confidence, knowledge about ways to support and empower victims of violence, or how to raise awareness and organize for prevention of violence. So we'll take a look first at Health Actions for Women, which is designed to help promote action, and it shares strategies and tools to organize and mobilize to address issues impacting the health and well-being of women and girls. The topics featured in this book are the result of formative research with health workers and health promoters globally who were asked what issues are most challenging for them to address. And that process involved exactly 41 community-based partners in 23 countries, plus several hundred health trainers and health organizers who also contributed their opinions and experiences. Perhaps not surprising to this group of attendees, the topic most frequently identified as challenging was gender-based violence and violence against women. You can see here the list of and the range of strategies and issues that were ultimately covered in this resource. One of the topics that was most frequently flagged as difficult for everyone working in this space was working with men and boys around gender-based violence. And well, actually, our respondents generally identified that working with men and boys around anything promoting women's health and empowerment was challenging. So this became a focal area for the entire resource. This is an excerpt from a discussion guide for men to begin to look at power dynamics and the links between power and violence and underlying gender-based violence. And this particular activity was adapted from a curriculum used in Oakland, California, and then tested and used in India. Here's another one that describes a discussion guide used with men in Oaxaca, Mexico. There are lots of other activities in this resource that can be used to help explore the harms caused by violence and harassment and to look at underlying causes. There's also examples of organizing strategies used in different contexts to prevent violence, in this case by women workers in Sri Lanka and by transgender women in Colombia. You can see that there's URL links underneath here just to help you find these materials if you're interested. As I mentioned, this was a hugely collaborative effort to develop this resource and then test the materials, as is the case with all of Hesperian's resources. Field testing of activities and draft materials was a major activity involving 41 community-based organizations in 23 countries. And ultimately, 1,400 women, girls, boys, and men participated in the process. During this process, groups were asked to pick at least one issue that they aspired to work on but had never addressed before, and to review and use draft materials on that issue as part of what they did for field testing. Really, they were quite courageous groups when you think about the kinds of topics that they decided to take on. So in addition to collecting rich feedback that enabled us to decide what stayed in the final resource and how to improve on that material, we collected information that allowed us to get insight into whether these resources increased the capacity and confidence and motivated people to take action on these issues. And we did this based on surveys conducted 6 months before the group received draft materials to review and test, and 6 months after they had reviewed draft materials and tried them out, or tried out the activities in those materials. And you can see a list here of some of the different issues that we were probing with through these surveys. Overall, the greatest increase in reported knowledge and comfort with any topic was around violence, gender roles, and sexuality. And violence in particular, 86% reported increased knowledge and 93% reported increased comfort in discussing gender-based violence after testing. They also reported more comfort and skills for leading those discussions, especially with men and boys. They reported learning new strategies and ways to be more effective with participatory activities. And most importantly, we were really thrilled to see that 6 months and beyond after being exposed to the resources, groups were motivated to initiate new actions and continue working on the topic of gender-based violence at a community level. And here's a few examples from Guinea and from Bangladesh. So let me also talk briefly about another resource that Hesperian developed that specifically addresses violence and sexual harassment in the workplace. The Workers Guide is a tool for low-wage factory workers who are mostly women, and it brings a worker-centered approach. Women workers identified many issues that aren't normally part of or considered part of occupational health as what they identified as workplace dangers, and lots of illustrations, and it too was field tested globally. You can see here the list of social dangers, again, that was developed based on feedback from women workers, that violence is chief among them. And the violence material that was developed in this resource was also adapted into a booklet on sexual violence and harassment in the workplace in Spanish and distributed as part of an awareness raising campaign in conjunction with the occupational health and safety networks throughout the US. So based on worker feedback, it frames gender-based violence and sexual harassment in the workplace within a larger framework of violence and harassment. Here you can see some examples. And it explains different types of sexual harassment. It provides ideas for that are useful for consciousness raising, and ideas for activities that you can do to raise awareness with women workers, and strategies and ideas for making sexual harassment more visible and to give women greater voice. And finally, activities that can be used to raise awareness about and organize against violence and sexual harassment in the workplace. Here's some examples. So the main approach that all of these resources take, and I think which is our shared goal here today, is to provide practical ways that really strengthen the ability to work with others and to mobilize for change, because it really is social change that is required to prevent gender-based violence at the workplace, in the home, and at a community level. So thanks so much for your time. Again, this is, and you can see my contact information. Feel free to reach out to me or find us at hesperian.org on the web. And if you're interested, there's a coupon code here, or a discount code that you can use to purchase any books, or just reach out to us. Thanks so much.
Thank you so much to all of our presenters. We'll now go into our question and answer session. If you have a question, you can either feel free to unmute yourself and ask the question, or you can put it in the chat box, and I'll turn it over to our moderator, Paulina.
Great, thank you, Michelle, really appreciate that. And I just want to take a time and just take a quick moment to thank each of our presenters for just the extremely important information that they shared with us today. As they said, this is a very, very sensitive topic. And so I hope that for those that are friends, family, or just a support system to survivors, that this was really helpful information. But to anyone on the call that is also a survivor, I just want to reiterate that you are not alone, and that the healing journey, though, takes long and is an arduous process. As a survivor myself, you know, it makes a difference to know that we're not alone. So along that line, I just want to say that in honor of this month's Sexual Assault Awareness Month, you know, a lot of the different suggestions that each of the presenters presented today was focused on how to respond to a survivor when a survivor speaks. And again, having been through this myself, I remember one of the things was, Priscilla, you mentioned this as one of the things not to say, and asking those why questions. Well, why did you do this? Why did you do not? And so I would like to just kind of pose this question to all the presenters, in how can anyone on the call today really kind of internalize some of these suggestions and some of these materials that you've shared with us to really best not only respond to any survivor that may open up to them, but also to really kind of help change, you know, just kind of this general sense, this general culture around violence against women. I know that's a bit of a loaded question, but I'll go ahead and open that up to any of the presenters.
Well, I can start very briefly by just looking at the issue of sexual harassment in the workplace. So I mentioned that we developed some materials to be distributed as part of an awareness raising campaign that was done by the Occupational Health and Safety Networks in the US. And that was a campaign targeted directly at low-wage women workers who are at greatest risk, perhaps, of sexual harassment, and certainly the group that tends to feel most impeded in terms of reporting. So this was part of an overall campaign to raise awareness, to sort of break down the stigma of even discussing this, and to help open up and raise awareness for women, even if they're not necessarily documented, to know their rights. And so that was actually quite effective. Again, it's a very difficult thing to measure, But it was a campaign that really did help reach a lot of low-wage women workers in the US, particularly immigrant low-wage women workers who feel less empowered to speak up.
Thank you, Sarah. That's a powerful response. And I believe that very much so a lot of women or a lot of survivors feel disempowered by what has happened. So just giving them that safe space to feel empowered to speak is so crucial. Thank you for that. Any other thoughts on this particular question? Okay, so let's go ahead and move to the next question. And so I know that in our first presentation, we saw the numbers on how the silent pandemic has really only unfortunately increased the rates of intimate partner violence, domestic violence, and very likely child abuse and sexual violence. And so again, I think really thinking about what this silent pandemic means, both culturally, not just in this country, but around the world, for us that are advocates to end violence against women, I think it's extremely important to have that knowledge. And as we're saying, knowledge is power, information is power. So in light of the silent pandemic, what are some key policies or what are some key, whether it's at the local, state, or national level, or what are some key efforts that maybe you all are aware of that all of us could maybe join behind or support or raise awareness about? And again, that's just open to any of our presenters.
Can you please repeat the question, Paulina? I got kicked off. So
no worries, no worries. So basically the question is, in light of the silent pandemic, which actually you highlighted in your presentation, what are some key initiatives or policies that are available to everyone on the call to support or to rally behind? And again, just bearing in mind that the silent pandemic means that this pandemic of violence in the home, violence in relationships has essentially increased in tandem with COVID-19. So what are just some general ways that we can be good advocates and good supporters of the End Violence Against Women initiative?
I think, advocating, I really think advocating is key. As I had mentioned, what we're going to see and what we've begun to see is this trickle down effect with survivors and victims of intimate partner violence also experiencing poor mental health. And, and they may engage in substance use as coping mechanisms. So really advocating behind for more support, more resources. We do know in the advent of COVID that there's been an increase in the use of technology, but that accessibility for technology in rural parts of the US is not adequate. So rural parts rural areas of the US are being left behind in terms of service provision. So really, I would just promote advocacy at this stage and for more resources.
I might add, and this is true in the US, in those rural areas and harder to reach women, but it's true globally that community-based actors, whether they're community health workers, formally or informally, or just leaders and community volunteers, really do play an essential role around this, both being a first point of contact, particularly as access to healthcare, formal healthcare services gets disrupted during COVID, but also in general, because those are women that may often not be able to connect directly with the formal healthcare service. So just sort of adequately preparing those kind of community volunteers who may operate in a number of different spheres. And this is where public health really brings its value, because public health is more than just healthcare providers, although obviously healthcare providers are a key part of that. So I would just argue, building on Jamila's response, that really that kind of preparation for responding to signs of violence, supporting survivors of violence, and also dealing with the mental health epidemic that will follow.
I love that. I think that's powerful. Thank you, Jamila. Sarah, Priscilla, I want to see if you had any comments. I know you talked a lot about the community health worker, and I actually do want to just make a quick shout out to any community health workers on the call that here in Texas, which is where I'm based, the Governor Abbott actually proclaimed a Community Health Worker Day on April 16th, because community health workers have been a really, really huge key point for a lot of our community. And so, Priscilla, did you have anything you wanted to add to that in regards to community health workers and what they can do in really informing survivors of their rights, or any advocacy efforts or initiatives that are happening at the local level?
Well, I just think it's a really big deal that we do recognize violence as a community health issue. I believe that New York State was the first state health department that actually issued a public health alert for domestic violence. So as you guys probably know, public health alerts, obviously COVID-19 was a huge public health alert. So different Zika virus, when it was kind of going out, got a public health alert. So lots of different things get public health alerts. But the fact that the state of New York considered domestic violence a big enough threat to public health to send out a public health alert to all healthcare providers in the state, I think that's a really big deal. So just kind of getting all states and systems to recognize that, I think will start kind of bringing the issue to the forefront more.
Thank you. That's powerful. And I actually wasn't aware of the public health alert New York put out. So I'm going to look into that. I think that's important, and maybe could become a national trend across all states, because it is a public health and a community health issue. So thank you so much. I know that we are close on time, so I just want to ask if maybe each of our presenters could just give some closing remarks in about 30 seconds, and then I'll pass the mic back to Michelle to close us out.
I'll start by just arguing for and thanking everybody for attending, but just the way that we can often silo health issues just because of the way health is structured. This is a case where, like, as we integrate awareness about gender-based violence throughout all of our work, we will strengthen it. So I would just argue for that as one final statement.
Thank you, Sarah. Priscilla, Jamila?
I can go next. I'd like to say that, as public health researchers and practitioners and community health workers, we really need to be mindful of the wide variation of culture represented by survivors, and of not only intimate partner violence, domestic violence, sexual assault, and really make sure that when we're responding to victims and survivors, that we are doing it in a trauma-informed manner, as well as a culturally tailored manner, because different cultures respond to things differently, and it's really important to keep that in mind.
Thank you, Jamila. That's powerful. Thank you for that reminder. Priscilla?
Sorry, my dog decided to wake up apparently. No,
he agrees with us.
Yeah, sorry. Let's see. I had a great statement, and then my dog distracted me. I know your resources. So that was what I was going to say, is that it's just so important to know what resources are out there. So just take a few minutes or a few hours to learn about your community and figure out what is all out there. Because for so many of us, there's more things out there than we ever know. And we don't want to miss out on helping a client when we could really kind of make that difference in that client's lives by just referring them to a resource. So take some time to learn about your resources. Thank you.
Thank you, Priscilla. And thank you again to all the presenters. I'll plug in some links in the chat, and I'm going to pass the mic to Michelle as we wrap up.
So thank you again to all of our presenters. Thank you, Paulina, for doing an amazing job with moderating. Thank you all for joining us. I just wanted to remind you, please complete the session evaluation. Even if you're not interested in the free CEU, we would definitely appreciate to hear from you. And also the evaluation includes a space for other topics related to women's health that you may be interested in hearing a webinar on. So please make sure you share your thoughts and feelings in our session evaluation. Also, please, if you're interested in the CEU, you can complete the registration through the link that I put in the chat. I'll also be sending this information out by email to everyone who's registered. I just wanted to also mention something that Paulina had put in the chat earlier. Our two organizations, the Women's Caucus and Latinx Voices on Saloon, are also partnering on another project focused on domestic and intimate partner violence, and it's called Breaking the Silence. You can learn more about our project at breakingthesilenceproject.org, where we encourage survivors to share their story through a number of different platforms or media, including audio, video, art. So there are a number of different ways that we encourage survivors to share their story. And finally, if you're interested in learning about either one of our organizations, please feel free to visit our websites or our social media sites. Again, thank you so much to our presenters and to all of you for joining. And you will be receiving an email. We will also be posting a recording of this webinar. So if you want to share the recording, I'll be sending that out to everyone who attended as well. So thank you all so much. Enjoy the rest of your day.